So hi everyone. Good afternoon. So I'm Emre Altıncı. I'm an assistant professor in the biology department. I have been working on different diseases, but I'm very passionate about type 1 diabetes research, and this is something that connected us during the Endocrinology Society's meeting this year. It was in San Francisco this year. So more than 10,000 researchers should participate in this meeting, and it's a great pleasure for me to host Dr. Huerta-Saenz today. So this is the second talk of a series that we dedicated to Caspar Augustus Ferguson, the first black student at Boston College, who graduated in 1936. So our goal is to bring excellent researchers, clinicians from different backgrounds to interact directly with our students. So a pleasure to have you as our second speaker. So Dr. Huerta-Saenz is a clinician and also a researcher. So she's a researcher at the UPenn, but working Penn State, but also working in the hospital with type 1 diabetes and type 2 diabetes patients and projects. So she was funded by different foundations, also the NIH, and she has been working on this autoimmunity inflammation markers, but also the nutrition component as well. She's originally from Peru, and she's an indigenous researcher. So this is also another layer of honor for me to have you as a speaker today. Yeah, so welcome.
Yes, thank you. Thank you so much. Thank you, Emre, for inviting me. And I am very happy to be with all of you. And as Emre mentioned, I'm an assistant professor of pediatrics and public health sciences at Penn State. Penn State is located in the central Pennsylvania region of Pennsylvania, so we do have access to many rural, semi-rural communities and beautiful populations that have very unique traditions. And I want to bring you to my journey in type 1 diabetes. I'm also funded by the Pennsylvania State University Clinical Translational Science Institute. I'm a ESI scholar until next year. So very honored to be with all of you. I want to start recognizing that we are in traditional lands of the Massachusetts and Wampanoag peoples, and I deeply respect their elders, past and present. I'm funded by the KL2, so then this is part of my work, and also my Department of Pediatrics. Before I talk about my study aims, I believe many of us have an inspiration to do specific types of works, either at the lab or in the clinic or the hospital. In my case, I never met any patient with type 1 diabetes in Peru, never, until coming to the US. And that was a very interesting experience because I did my residency in pediatrics in North Philadelphia area. So most of the time in 2008, when I was in residency, my work was with type 2 diabetes. And then life brought me to Kansas City in the heart of the Midwest region of the US. And then I suddenly moved from one patient with type 1 diabetes every 3 months to 4 to 10 children newly diagnosed with diabetes weekly. And my perspective of diabetes was definitely drastically moved by that experience of conceiving children who were really some of them in coma, some of them with acute kidney injury. And through that work and the work of my mentors, because I was trained in type 1 diabetes care daily for 3 years, my interest to change and impact the lives of these children started. So this is for all the patients that I have been taking care for the last 10 years as a clinician. I really hope that we can help them to, number one, hopefully one day to avoid the disease, or if we find the disease, we find the disease in the pre-symptomatic phase when we can still save many beta cells. So one of my observations as a clinical fellow was that when I was trained as a fellow, the whole goal in 2011 was, as long as we match their foods with insulin, we should be fine. So then the kid, just right after DKA, when finally the kid was allowed to eat, maybe 6 donuts, maybe more cookies, maybe more pasta, and as long as I count the carbs, everything will be fine. And I was like, this doesn't make any sense. I took biochemistry, right? I know how, the pancreas works. So the pancreas is sick. There is a lot of inflammation, many molecules, endoplasmic reticulum stress molecules activated. And why in the world I need to allow this poor child to eat all this humongous amount of carbs, at least maybe 120 grams of carbs in the whole meal, between cookies, pasta, and juice? What is the concept of metabolic rest if the pancreas is telling me, please help me? So then there was something that really didn't have any consistency between what I was told to do by my clinicians, by my teachers who were clinicians, and what I was reading daily in Science, Nature, New England Journal of Medicine. There was a disconnection, and I was like, this doesn't make any sense, because I don't know why I cannot modify their nutrition. So then this inconsistency between what the clinical guidelines mentioned at that time, 2011, and what I knew was happening inside the pancreas definitely were my initial step to think like there is more to do about guidelines and clinical care for kids with type 1 diabetes. So then I noticed that a group of them who clearly told me, by the way, they came with an A1C after 1 year of being diagnosed with clinical diabetes, A1Cs of 6.5, 6.1%. And I was like, this is fantastic. Tell me, how do you do this? And then the mom told me something very important. So as a pediatrician, I listen to the moms, I listen to the dads, I listen to grandma, I listen to the adult who is taking care of that child. And the mom told me, I don't do what you guys told me to do. Oh, this is interesting. So then he eats mostly, veggie noodles. I learned about these magic noodles. I learned more about the combinations that they were doing. They were doing some gluten-free or some low gluten, and then he needs to do physical activity. His glucose levels are between this range, and I need to do that. And the mom was telling me what she was doing to keep this child in better metabolic control, in great metabolic control, and she clearly told me that she didn't follow the guidelines of a specific team member who was following that child. And because this is a family that was really into science, so then they advocated for technology, type 1D technology, so CGMs and pumps ASAP, just few weeks actually after diagnosis. They were so fortunate, like dad has an engineering degree, so then he took all of that. And then it was like, so then you really are using only a small amount of exogenous insulin therapy, and I really need to keep this model for my other children who were not there, A1Cs at 8, 9, 10, 11, multiple DKAs. So something needs to change. So then the only way to do that is, okay, I need to find more kids like you. I need to find more remitters so I can learn from them and try to phenotype, investigate what makes you so different and unique than the other kids. So then I started to investigate more about which specific diet exposures were playing a role or influencing the development of partial remission of type 1 diabetes, also called honeymoon phase. And then I also wanted to investigate further about the omega-3 index as a marker of inflammation, potentially. And then I needed to investigate further how some systemic inflammation markers, such as cytokines, can also be influencing the development of partial remission. For those who are not totally familiar to type 1 diabetes is an autoimmune condition. It's not only a metabolic disease, it's an autoimmune condition. And it doesn't start when they come with a polis here. This is the pointer, yes. Which one do I click? Yes. So then when I was a fellow, 2011, we didn't know anything about the staging of type 1 diabetes. The staging for type 1 diabetes that we know now was published in 2015, and it came from a beautiful multicenter study called TrialNet. funded by the NIH, NIDDK, and also JDRF, now breakthrough type 1D, where we learned that when we see patients coming with polydipsia, polyuria, polyphagia, it's already too late. This is stage 3, symptomatic. It's a symptomatic phase. This is far before that. So through TrialNet, we were able to identify patients with antibodies here, and we learned that the process of autoimmunities are far before. There is a first phase where we don't have any issues with the glycemic control, so they're euglycemic, no symptoms, and then that is called stage 1. Ideally, we would like to identify them at this point, basically with type 1D antibody screening, and then some of them, many of them can progress to stage 2. They continue with the autoimmunity, and then this glycemia. In children, right now, I think I will talk about that maybe later, but the point is, dementia is still pre-symptomatic. I believe that there may be other symptoms, far different than the polys, that we can identify in children. I don't know about that in adults, but remember that insulin is not only a hormone, it's a growth factor. And the big difference between children and adults is like they still grow, we don't. So then, that is for future talks, but most of my patients, I will say like 98% of them come in clinical phase. So then we all learned at that time, even for decades we have been talking about this honeymoon phase, beautiful phase. How we define if someone is in honeymoon phase is when the A1C, this is the old definition, less than 7.5%, or when the total intake of exogenous insulin was less than 0.5 units per kilo per day. And that is putting together the long-acting and also the short-acting insulin. So then in 2009, the research about how to identify honeymoon phase in the clinical setting started to come out. So in Europe, they did a very beautiful study where they correlated this index with big C-peptide in a mixed intolerant test that is a gold standard to determine beta cell function. And they came out with this beautiful index called insulin adjusted hemoglobin A1C index. You have the formula, and then as long as it's below 9, then you can tell the family your child is still within the clinical partial remission, also called honeymoon phase. We can continue. The question is, do we have guidelines to take care of children with honeymoon phase? Not really. I mentioned briefly about these other markers of beta cell function, and then this is the formula, and the truth is, like, unfortunately, less than 30% of kids with type 1 diabetes remain within the honeymoon phase. There is a beautiful immune phase where patients have some degree of immune tolerance, they recover some beta cell function, and they continue. Not only continue, they restart their endogenous insulin release that initially was not at that point. So more details about, these are the ISPAT guidelines. I went there to present some of this data in Portugal last year. But this is beautiful, and this came because of TrialNet. So my work when I was a sub-investigator for TrialNet for Kansas City in UMKC, so then I went to the community to tell this information, to spread the knowledge about these guidelines to the rural Kansas practitioners, so they can start looking for antibodies in siblings, family members of adults with type 1 diabetes. So what are the metabolic effects of prolonged remission or partial remission, also called honeymoon phase? This is a beautiful phase where they really require small amounts of exogenous insulin. They have less glycemic variability, and that means better cardiovascular health outcomes. They also have reduced risk for DKA. One of the concerning events is recurrent DKA. Each DKA is literally an earthquake for the pancreas. You lose a lot of beta cells, so if we can prevent DKA, that can save years, months of beta cell function for the patient. And then from the DCCT, these are long epidemiological studies looking at microvascular complications. Patients who have prolonged honeymoon phase definitely have less chances to get microvascular disease and less odds to get end organ damage. And of course, better quality of life. It's better to only use 15 units of insulin than being on 75 units per day, right? So potential mechanisms, what brings the honeymoon phase to these patients? So then there is a combination of, once you start insulin therapy, there is less glucotoxicity, that by itself can help. There's less reduced lipotoxicity. We have this concept of beta cell rest. I tell my residents, if I have COVID and then my division chief asks me to be on patient call for 2 weeks, I will crash, right? Because I'm sick and I need to do work. If the pancreas is sick and we keep giving the pancreas 108 grams of carbs daily, that wouldn't be nice. We need to allow the pancreas to heal. And the metabolic rest can be done with exogenous insulin therapy. And then of course, from the immune perspective, and that is where Dr. Altindis and his team comes, you know more about the cytotoxic T cells, how they respond Th1, especially Th1 for type 1 diabetes. And then for those who do more like endoplasmic reticulum stress science, redox components, and the immune therapy, we only have one medication that we're very happy to have, at least toxin remission to some degree. So we learned that children who develop honeymoon phase after 1 year, they were different than the other kids. Typically, they were diagnosed at older age. There's some data from, proposing like typically it's around 7 years old or older children have higher odds to get into remission than those diagnosed younger than 5. Then males somehow are lucky because they typically are the ones having higher prevalence, higher incidence of remission than the other females. And then those who came with lower A1C, who were not on DKA, so they were not really metabolically unstable and have persistent residual C-peptide, also have higher odds to get into remission. And there was some papers, again, there is some conflicted data about that between how many you have single antibodies versus multiple antibodies for the immune activation. And that is, this is some data about nutrition. So this was done by Search. This is a beautiful epidemiological study, multi-center, completed in the US with pediatric and young adults. And what they did is they looked into the dietary intake and fasting C-peptide. What they found is that those who have higher vitamin D levels, they found some correlation, with a fasting C-peptide above 0.3 to 0.23 nanograms per ml. Vitamin E was not to that level, neither the omega-3, measured by EPA and DHA. But when you have that combined, there was some correlation. So what they mentioned is, and again, this dietary intake was self-reported, okay? And then we did also, they did also levels. But that is when I started to base my initial attention to the preliminary data related to nutrition factors, promoting, supporting some degree of residual beta cell function. Lately, we had some single nutrient clinical trials. This was specific to high-dose ergocalciferol by Dr. Nwosu from actually he works here in Massachusetts, and his work was related to test high-dose ergocalciferol and beta cell function, and they found that even though ergo didn't really cause remission by itself, patients on the high-dose ergocalciferol, they have better trends on the A1C and also some in the TNF-alpha. The beta cell protection, based on his data, was comparable to prior immunologic agents such as imatinib and also verapamil. And one of the conclusions was that vitamin D may complement the work done with some of these immune therapies for residual beta cell function. So this is real data. Unfortunately, our youth with type 1 diabetes, even though they see dietitians, they see diabetes educators, they see pediatric endocrinologists, they still eat low quality foods. The question is why? So they receive the knowledge, they receive the theory, and the question is, do they implement that knowledge in their daily routines? I was talking with Charlie just before coming here, and we're talking about who can translate science to the daily table in the families. So then many times, it's not necessarily the basic scientist, but the basic scientist can talk with the clinician, and the clinician can talk with the policymakers, and then that is called implementation science. Because despite of all this beautiful science that we have, they still eat bad quality food with the potential consequences of not only further damage of beta cells, but also the metabolic complications, such as we see metabolic syndrome, we see obesity, we see metabolic associated liver dysfunction in these children. Omega-3, there are many studies, I'm not an omega-3 researcher by itself, but through some mentors, I was able to complete this study this specific measurement called omega-3 fatty acid index with DBS technology, dry blood spots, and get some of these levels. And they have many data about cardiovascular disease, and I tried to see if that can correlate with the remission of type 1 diabetes. So we all want to really improve glycemic control, because in different pathways it's going to be better for the patient and also for the beta cells. And that is how my study came. It was a case control study, and I wanted to determine if a specific dietary exposures correlate with partial remission in children who have been living with clinical diagnosis of type 1 diabetes for longer than 1 year. I also wanted to investigate if the islet antibodies and related autoimmunity, specifically celiac antibodies, transglutaminase IgA, and adrenal antibodies may be playing a role. And then that was my first work with serum cytokines. Before that, I haven't really worked with cytokine profiles, but that was, I needed to recruit mentors to teach me how to do that. So then the best way to do this study, I needed to identify cases of remission. So this was a case control study. I collected, of course, the classical social demographic data. And as a pediatric endocrinologist, I really care about puberty, because puberty is a really special moment in life, very different from adults, where you have a burst of a lot of hormones that have a different type of release pattern. And I wanted to investigate that further. And then this was our initial ratio. I needed to do some modifications, so I changed the ratio to, instead of being 1-3, to group match. So then once I identified the cases, they were, even though I was looking kids between 1 to 17, when I recruited the cases, they were between 5 to 17. So they basically match group control. Okay, I told you about the IDA coefficient. So this is how I determined who was a case. We obtained data of the 24-hour or at least 2 or 3 days of insulin logs. If they have a smart insulin pen, we got data from the smart insulin pen data. If they have pumps, we got the data from the pumps. And as long as the IDA1C was equal or less than 9, they were called remitters for our study. So that was our study definition. And then we use omega-3 index for the DBS sample. These were some of my secondary outcomes. I aim for 8 cytokines. Not all of them will have values within an expected range, so then we need to remove a couple of them. We ordered the antibody through my mentor's lab, Dr. Michaels and Barbara Davis. And then my nutrition scientist mentor trained me to run the ASA24. ASA24 is totally free. It's a dietary intake online report. You do questionnaires, and it's funded by the NCI, National Cancer Institute. Initially started for people with cancer, but then most researchers have been using this platform because it's free, okay? And it has interesting data. And of course, we obtain glycemic metrics. For those who were on CGMs, for those who were on glucometers, from glucometer logs. I don't know how familiar you are with the interpretation of the data, but the use of 24-hour CGMs has been a remarkable change in the life of the people with type 1D. I need to say that one of the things that has been really hard for me to see in children is they cry, they show me their fingers, and I can tell them, we know it's, I have tested all the devices on myself when I was a fellow. Just name it, the pump, name the CGM, name that glucometer, because I don't have diabetes, but how can I talk with a child about diabetes if I don't do that to myself? So then that was not mandatory, but I think like in my fellowship, we were all given the opportunity to do trials with technology, and it was up to us to do it, so I did them all. And then I learned like, this is not easy. I only did it for 1-2 weeks, and people did their whole lives. I said, well, I need to do something about this. So my clinic, is very fortunate because as soon as I come to the clinic for the first education, all of them are given CGMs. We can cover them with funds from CMN, Children's Medical Network. It doesn't matter what is your health insurance, you will get a CGM, as long as Pennsylvania State keeps paying for that. So thank you for their funds to help us with that, and nonprofit organizations, so then they get that. So that is one way to basically reduce that social bias based on health insurance. That was not possible when I was in Kansas City. I need to say that it was really hard to get CGMs at that time. But in Pennsylvania, at least in my center, they all get CGM as soon as they walk into the clinic. As long as they don't refuse to have a CGM on them, we place one, we get data, we get the data in the cloud, we call them daily, because our job is to be sure we're able to reduce the beta cells toxicity, and they have someone to talk with. And when I'm on call, I'm 24 hours available for them. So this has been amazing. Before I get there. So then for those who don't live with type 1 diabetes, so then right now the guidelines are, we need to keep the time in range. You love the traffic lights, we don't want to speed up and cross the highway when we are on red. We need to be in the green area. So from that perspective, it's very educational to families, to people, that we try to be around 75% or above. Once you have diabetes, there is no 100%. And we need to be flexible, we need to accept that, and it's okay. As long as we try to keep you most of the time on target, it's okay. You need to forgive yourself. Because I also have some patients that have some of my OCD traits. It's like, oh, it's okay. One day is one day per day, okay? So then we were able to recruit children and adolescents. These were my inclusion criteria. They needed to have at least one positive antibody, and they needed to bring the data for the total daily intake. Okay, they could be in any methodology, injections, pumps. Most of them were on CGMs, but there were some that really didn't want to have CGMs. This was a case control, so then I still allow them to be part of the study because we care about what they were doing. Okay, so remitters, non-remitters. Okay, so then we had a great acceptance from the families. Many of them say no, but many of them say yes. And this is some of the demographics. I share some of my abstract with Dr. Otindi, so then I hopefully my primary mentor is going to be happy with the versions. She's a perfectionist, and that happens a lot in science. So I think we're in a closer pathway together. So then I recruited 84 children. 21 were the cases of remission, 63 controls. You can see the data, even though it was not significant, the majority of them were males. And then the age, I live in Central Pennsylvania. This is very reflective of our demographics, so mostly Caucasians from different types of populations. I have huge Amish, Mennonites, and just, kids of different other neighborhoods. Non-Hispanic, most of them. And then, I think for my study didn't really make a big difference, the insurance type, because no matter what they have, we have CMN funds to cover and to help those who didn't have enough money to afford insulin, because insulin is very expensive. So then this is not necessarily the reality in other clinics. So I didn't collect HLA genotyping. So then my way to overcome that is asking about family history of type 1 diabetes in first or second degree generations. And most of them, you can see that they didn't have any family history of type 1D. It came from nowhere. And that's why it was shocking for the families. And you can see the duration they need to live with type 1 diabetes for at least 12 months. So this is also some of the data about how they came. None of them were significant for my specific study. DKA, most non-remitters have DKA, but this was not significant. We look into the pH, we classify the severity of DKA, mild, moderate, or severe. That was also non-significant. A1C, you can see very similar in both of them. These are means because it didn't have any normal distribution. Plasma C-peptide, plasma insulin level, and so none of them really were significant. Sorry, because that looks a little bit tiny, but This is some of the data that we have. So what we found is definitely that total daily dose was significantly lower in the remitters. That you can see the IDAA1C, even though I think I talked with Aubrey about this. If you take a look to the mean A1C in the non-remitters, okay, I would say, knowing that I have patients that have 14%, 10.8 doesn't sound too bad, even though it's not optimal, for sure. But just that means we're not crucially, even though they're significant, I thought that this will be more like 12, but it was not in that way, because who is enthusiastic about doing research? Which type of family is enthusiastic about being part of research? So families who have typically college degree, families who have been able to learn and read about science, and many times that's not a situation with families who maybe only were able to achieve second or sixth grade level education, right? So then, again, whenever we publish data, whenever we collect data, we need to be aware that some people were not part of the trial because of different SODH, social determinants of health reasons. Maybe they were not able to have a right to come to the study. I was not able to provide reimbursement for mileage for this specific study. So this is a partial data of the reality. Okay, so this is very important. As a scientist, I cannot mention, okay, this is gonna be translated to the whole population. No, and this is data from Central Pennsylvania, okay? So then insulin delivery type, you can see that, most of them were on pumps. We love pumps. If they want to have pump, okay, as soon as you learn the basics, we go with you. We see which pump is covered by your health insurance, and we are there. I have a beautiful team we do outpatient education, so then as soon as they're stable, clinically stable to come and walk to the clinic, we talk about technology from day one. This is very important, okay? Glucose monitoring. This is not the reality in many. If I see data from California, there's a beautiful study just published from the teams from Children's Hospital of Los Angeles. They don't have that same situation. Technology is a big deal over there. Again, all my patients have CGMs because as soon as they come to the class, we have a CGM ready for them. So then for us, technology was good. A1Cs, and then glycemic metrics. Look at this beautiful CGM metrics. I don't know if we have type 1D people in this session. You can see, look at this amazing timing rate, 79. That is great, that is great. And they feel great. And they feel like, they also feel that they're achieving something that is good for them. And when you win your personal victories, that makes you feel self-confident. That makes you feel optimistic. And, good mental health helps also your immune function, right? So then I'm not going to talk about the mental health of people living with chronic diseases, but it's important when you take care of a child to let them know it's okay, you're doing a great job. What else I can help you, I can do to help you, or to help mom, to help dad, to keep moving forward. Okay, and that message means a lot for them. Okay, no one likes to fail. It doesn't feel good. But if someone tell you, hey, these last 2 weeks were not good, okay, but it's gonna be better tomorrow. I bet. Because it's going to happen. So then you start the next day with a different mentality. And this is a lifetime condition. Even though we don't like to talk about that daily, this came and it's gonna stay until we find a cure. So we need to learn how to partner with that condition to keep enjoying and having fun every day. Okay, and the omega-3 index, again, 2 things that I learned about the omega-3 index. That based on the reference ranges, this value should be ideally above 8. So both of them have low values, right? And that data came from cardiovascular disease research. So we don't know yet about omega-3 index in type 1D population. This is an autoimmune condition, so maybe it needs to be even higher than 8. We don't know yet, okay? But the data for the reference range came from cardiovascular disease research. It was not significant, but I will show you some other data. And then look at this beautiful 25 hydroxyvitamin D. I love vitamin D good levels. Yes, the remitters, and I didn't give them anything because this is case control. They came for a visit. I did not intervene on them. I captured the data. But many of my remitters were on supplements because the families wanted to do that, and they ate differently, and that is what happened. Okay, antibody status. So then you can see, I didn't have any role with the diagnosis. It's whatever antibodies they came with. Anthropometry and enrollment. We have look at this. Many times when you think about type 1 diabetes, people mention, underweight, normal BMI. No, you also have, if you add together obesity, the kids with obesity and overweight, 25% of them still have high BMI. And that is, I know, only one of the measurements of nutrition, but I wanted to point that because this metabolic syndrome happening, MSALD happening in kids with type 1 diabetes is real. Either combined because of diet, either combined because of this gradual development of peripheral insulin resistance is happening and doesn't help in the equation. And we need to do something about that. I think I showed you the glycemic metrics, the omega, the IDE1C. Okay, omega-3, and I think there's one slide that is missing from my nutrition data, so I'll be able to check that with you in a few minutes. But this is omega-3 index, so then we're checking this again because if you take a look, it shows some negative correlation with the IDA1C, not with the A1C, not with the total daily dose of insulin. Of course, some of them was self-reported because for those who have glucometers, but the 25 hydroxyvitamin D was not significant. Again, is this only because I have only 21 cases? Maybe. So this is going through more scrutiny by my data interpretation and analysis team, so we'll see how it goes. Amazing. There was a slide about the data and the nutrition, so I will maybe is at the end. But what I found about the nutrition, okay, is that remitters. Let's see if I don't see that. Okay, so then maybe it was cut. Okay, so I will show you that later. But we found that the remitters ate less amount of carbohydrates. So their energy from the total daily energy intake. So the percentage of carbohydrate intake was around 42%, between 35 to 42%. So then that may qualify if I only look into the 24-hour data, because it's 24-hour dietary intake, a little bit in the moderate low carb. It's not diet because I only collected one day. So this was not a meal pattern. And then when we specifically studied which type of carbohydrates they ate, remitters ate less amount of refined grains. We didn't find that data for fiber, but when we did the healthy eating index, their scores were better than the non-remitters because of the reduced intake of refined grains and more vegetables. When I mention the vegetables, I'm specifically talking about greens. And then they ate a little bit more legumes than the non-remitters. So, and of course the vitamin D reported intake didn't have any correlation, but because we had the biomarker, the 25 hydroxyvitamin D, that was significant. So then that also, translated to when we only do self-reported data, it's not as accurate as doing nutrition biomarkers. It's very different, right? Very different. So then it could be subjective data versus what is the reality. And the question is, what is the right biomarker? But with 25 hydroxyvitamin D is very standard. Omega-3 fatty acid index, there are not too many studies doing that. I think definitely in my institution, this was the first time. And what I learned from this initial work, funded by Transmiracle Network, this was my first grant ever, so then that was very exciting, was that the quality of dietary intake was low in both, but remitters ate better than non-remitters. And specifically for the omega-3 index, it was below target in both of them, although remitters have better omega-3 fatty acid index. And then we need to have further investigation of the role of omega-3 and vitamin D intake. And of course, this was only 24-hour diet intake. So then I think it's going to be important that we don't only focus on A1C, right, time in range, but also how they eat early in the disease. If we are able to identify them at the stage 2 of type 1D, great. But the majority come at stage 3, and that is where my work is right now. I'm doing a nutrition intervention in children newly diagnosed with the stage 3 type 1 diabetes. It's a 12-week nutrition intervention. It's called NutriBeta. It's in clinicaltrials.gov. You can find more details. I have funding from the CTSI to enroll 20 children completely, and I'm very close. I have enrolled 17 children within the first 60 days post-diagnosis, and 9 have completed the trial. I cannot give more details, but I have seen beautiful GMIs, and I'm very happy about that. And 0 DKAs, 0 ED admissions in the first 12 weeks. So then that is huge, because one of the concerning things happening just right after diagnosis is admissions, severe hypoglycemic events, seizures, and all of that. And this is, I will, there are more names, but this is my team. It's an interdisciplinary team. So my boss and my colleague, so I partner with a pediatric hospitalist, because we're only 3 faculty, so 3 pediatric endocrinologists in my division, so we're a small division. But Colin is a chief of the pediatric hospitalists, so then he knows a lot about inpatient care, and he likes science, so then he's also helping me with the supervision of some of these study visits. And then Maxime is a exercise physiologist funded by the CTSI, the Cancer Institute, and he's an expert in physical activity. We know that physical activity also make an impact, right, in how our beta cells respond to insulin. So then he's teaching me more about that. And David Bradley, he's the director of the Adult Diabetes Clinic, and he has done a lot of work for MMTTs and IVGTT. So then I learned my mentors from the KL2. I have more mentors than it's a huge list. So and then my coordinator, and then I have some undergrad. I'm very happy. I only have two. I think it's Ashka and Faiza. The other ones are medical students that really want to be part of the team and get exposure to clinical trials, diabetes care, my dietitians, and so CTSI is funding me since 2022, and then CMN was the main funding for this study, and that's it with this presentation. Happy to ready for questions from you guys.
So thank you. So if you have any questions for Dr. Huerta-Saenz, please. And I forgot to tell, we have lunch here after the talk, so we can continue to this conversation during the lunch as well. And Dr. Huerta-Saenz is going to also meet with undergrad students and give another talk at 4 p.m. about her personal story. I forgot to talk about this. So, questions? So, Carmen?
Early in your introduction, when you recorded a study that was in 2012, that was a beautiful pie graph that was showing most of the dietary intake was of grains.
Diet quality, the pie?
Yes.
Okay, yes.
I wasn't sure, since that's about 10 years old, if a similar study has been done, like that's a recent information of the dietary intake of some of these patients, since possibly with the use of like social media, a lot of people are coming to understand some scientific language and the effect of diet. So I wondered if maybe it's adjusted in a positive way, but I wasn't sure if there were any recent data about it.
Yes, so great question. So the study from Tonja Nansel, actually she worked with Dr. Lafell and the group from Jocelyn, so then they did that study over there. Yes, it's an older study, but it was a very nice study in terms of the composition of all the nutrients that they have. I have not specifically compared the value, but the proportion, the diet of youth living with type 1 diabetes is still based on mostly carbohydrates. But we have seen a trend for families and patients to adopt other eating patterns such as paleo, ketogenic diets, or low carb diets. We definitely have seen that in the last, I would say, 5 years. Actually, I have a family who moved from North Pennsylvania. They were going to a different institution in that area, and the family contacted me through that trial. They found my name in internet, and because they didn't feel supported, because the mom wants to have low carb diet, and the clinical team didn't really supported that. They were not happy that she was doing that. She emailed me. Her daughter was out of this. My trial is you need to have 60 days post-clinical diagnosis. So then she was out of that period of time, but I told her, I can still help you and support you if you want to come to the clinic. And I feel very honored because she's a family coming for 3 hours and a half away to see me. I do virtual visits, so then we do 2 in-person visits, and she's on low carb. She wanted to do low carb, and I said, like, that's fine, but remember, she's growing. She's not an adult, right? So I still need to monitor growth rates. I need to monitor puberty. I need to monitor healthy periods, because most of the energy comes from carbohydrates. They are needed, right? But they are needed in different proportions based on your growth phase, your energy needs. If you are an athlete and you need to consume, 2,100 calories per day based on your energy demands, you're not going to eat similar to someone who is doing just walking in high school. So that concept of food is our energy, and how we distribute the energy in different macronutrients, so it's crucial. And I need to admit, sometimes clinicians don't have that background, and that doesn't allow them to provide support for those families. So then, she's doing low carb, A1C 5.8. She's still on the honeymoon phase. MDI, she doesn't want to deal with pumps, and that's okay. So I cannot force a family to do a regimen that I believe is good for me. It's about what is good for that child. She's 15, 16, so then she will change, Once you are done at stage 2, your body may change when you are post-menarche, right? And that is a different story. You may behave more like as a young adult from the metabolic and physiologic perspective. So then, yes, there was an abstract at the ADA when we met about I think it was in Los Angeles. I need to double check where they just look into, from the whole clinic, how many of them were looking into paleo, low carb, and ketogenic diet, and we definitely saw the numbers were higher than 5 years ago. And for those who are interested in those type of trials, Dr. Lenners from Boston Children's is doing a clinical trial for children with type 1 diabetes. It's a 9-month ketogenic diet. So yes, and she's doing a great work over there. We talked to I was introduced to her, and we have talked and helped each other to see how we can increase our recruitment numbers. Yes.
Speaking of keto and paleo diets on social media, have you seen some of the flip side where you see patients come to you with diet fads that might not be so scientifically accurate?
Yes. So then I saw, I think, a couple who didn't even, again, they wanted to take that initiative. And adolescents are a beautiful group, but you also need to validate their interest, right? They did that without any nutrition professional. So then I'm not a dietitian, so then when I support families with paleo, ketogenic, low carb, I work with my dietitian, and I explain these concepts of you want to do that, but at the same time is how much energy your body requires. So then we saw lipid profiles that were not okay. So we obtained a fasting lipid profile, we obtained liver function, and we explained we want to support you, but remember, if you only use this specific macronutrient, you will switch, you will make changes in how your energy is coming from, and we need the specific molecules for all the biochemical mechanisms that you have seen that we have in the liver, happening. And I think once you validate that they want to take the initiative, that's great, but we also need to learn what is needed, what is safe. So Dr. Leonard's trial, one of the main outcomes is safety. So then I told them that I will support them clinically, but we need to have professionals to help and guide them in that effort. Yes, great question. Because you see a lot of people on Instagram, influencers saying blah, 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 blah. And then you ask the influencer about, do you know about puberty? Do you know about their needs? Do you know about, that how many other macronutrient deficiencies the kid may have? This is a teenager who's having their menses monthly for 6 days. Do you care about her iron level? And they're like, oh no, so then you need to mention that you need to have a healthcare professional. There are people who went to school, nutrition school, so they know about that. So then I think that's why diabetes is a multidisciplinary care. Yes, great question.
For the omega-3 index, is that simply just the ratio of 6s to 3s? And what is the importance of that in managing diabetes severity?
Yeah, great question. So then we're trying to know that answer, okay? Because most of the data about omega-3 came from cardiovascular research disease. Now they're checking for Alzheimer, they're checking for autoimmune conditions, they're checking that for even asthma, right? Atopy. So then the omega-3 index that was developed by Bill Harris, Harris, he has this lab in South Dakota. So then it's a combination. It has different indexes. You can see it has a DHA, EPA, but also has other markers. It comes with a lot of markers, AA, okay, and I'm not an expert on that. So then my mentor, Phil Chinton from Arizona, is helping me with that. But there was no data specific for type 1 diabetes, okay, except for the search data that I show you. And that was with plasma levels, not with the DBS technique. But we believe that the red blood cell marker, because this is specifically, we're basically poking the finger of the child, is a more accurate or more sensitive indicator than the plasma, because this is specifically how the red blood cells are getting exposed to omega-3. So we'll see. Again, from my study, I cannot make that conclusion, right? Because it was a cross-sectional study, but I learned 2 things: that everyone has low omega-3 fatty acid intake, but hello, this is Central Pennsylvania. We only have tilapia, maybe mahi-mahi coming from somewhere, cod and catfish, okay? Maybe trout, okay? But I would say that most of my patients don't eat seafood, do not. So then, just starting by that concept and telling them, hello, the national recommended dietary guidelines specifically mention we need to eat seafood twice a week. So then, and that is not happening. With or without diabetes, they're not adherent to the guidelines, and we know that that is good for their health. So then we can, as a clinician, I start educating them about what we know, regardless of type 1 diabetes. I think that people with autoimmune conditions may need higher intake, but I don't have scientific data to support that yet for type 1D. We'll see what I'm going to find in my next studies.
Quick question. So when I was first diagnosed with type 1 diabetes, I was advised to stick to using needles at first so that I could understand how to manage my type 1 diabetes before relying on the devices. So you talked about how that you guys can get these devices right away. Have you noticed any effects on the management of children with type 1 diabetes relying more on the devices rather than the actual injections?
Yeah, great question. So what they get from day one as soon as they come to the clinic is a CGM, not a pump.
Oh.
I tell them we need to learn the basics. We cannot send you to college if you don't do kindergarten and elementary, okay? You may be a pro, but the only way to know is, number one, insulin pumps are amazing, even especially the ones that have automatic insulin delivery mode, but they are machines. They may fail, okay? And if you don't have the insulin pump running and you forgot the basics, we are in trouble, right? You can call us right away, but you need to know how to handle the situation without the pump. So then they must master the MDI regimen, and then they're invited to come to the pump information class. What is from day one is definitely 24-hour CGMs.
Yes. This is like a future question, but for the remitters, are you planning on tracking how long that honeymoon phase extends compared to patients who have, like you haven't ever looked at? Because I know there's like a typical duration for honeymoon, but now with this question of remission, it's like, does the honeymoon phase become extended?
Yes, so then that is my goal. I'm trying to find, to help, to contribute with a community of researchers studying this beautiful phase of residual beta cell function. I don't know if nutrition will be the only one. I think it's more like a complementary support, at least at the stage 3 phase. For the clinical trial, this is just a cross-sectional study, so the clinical trial that I have running right now, I'm following them for 6 months. Again, only 30%, based on the epidemiological data, only 30% continue with honeymoon phase after the first 3 months post-clinical diagnosis. So then I'm following the first 6 months, and I'm comparing how many of my intervention group continue with honeymoon phase versus the ones on the control group. I have only 20 kids, but it wouldn't be fantastic that 50% of the intervention group continue with honeymoon phase after 6 months, knowing that that is unusual. And the only thing that I did was basically intensive nutrition counseling with 6 selected food groups. Because I think as a mom, if I tell the family, we did a study, it was a small study, but guess what? 50% of the kids on this intervention were able to continue with honeymoon phase. Can we try? Because this is safe. It's basically foods, high quality foods. You continue with your pump. You continue with the CGM. I'm not. This is insulin is a cornerstone therapy, right? But I have families who really don't want to. The whole idea for me discussing a potential drug, IV infusions, just scare them, and knowing that it's not going to assure that they will get 100%. Non-progression. So then you also need to look about what is feasible. These are children, they go to school daily, mom works, dad works. So that is my goal, to offer them in the menu. I am Taiwan, that is like in the menu, so then these are non-medical treatment options, okay, or complementary options in addition to your medications. It would be nice to tell them, we can also help you with this, right? Because every family is unique, every child is unique. But that is my goal, to support residual beta cell function.
In the study, do you account for if behavior change, like if I'm participating in a study that's going to test me on my glucose levels, I am going to change how I eat?
Yeah, because this was a cross-sectional study, so it was only one visit. That was not, I didn't measure quality of life. But for my NutriBeta study, I feel like all of us know that when I give them fresh foods, when I give them 7 sessions of nutrition counseling, because that is my clinical trial, I give them 7 sessions of nutrition counseling, 1-to-1 sessions, I'm making a behavioral intervention.
How do you account for the quantification?
Both groups get the same number of sessions. 7 sessions of nutrition counseling. The main difference is the content. Okay, this is more like anti-inflammatory foods. This is my plate, so the standard of care, my plate health model from the USDA. And then I'm also trying to homogenize the social situation. Both of them, this intervention group get fresh foods ordered to their local grocery store weekly, and the monetary value is similar to the grocery store gift card that they get. So that is how I'm trying to homogenize the potential bias of family, like not being able to access nutritious foods because of budget.
I guess I just have a question about remission in general. So like somebody like I talked to you about, my brother, who was diagnosed in 2005, the science wasn't necessarily the best, and maybe he didn't undergo as long or intensive as like a honeymoon phase.
And he was 3.
Yes, exactly. So at a point now where it's been 20 years, where his beta cell function is to not be at is there any chance of trying to improve, like trying to get some like remission-like factors in people who have had this disease for so long? Is there any hope for that, or is that kind of something that isn't really applicable to the study?
So the data has shown us that longer time with a condition, less chances because there's more destruction of the tissue, right, of the pancreas, and that has been confirmed with even images when they do the studies. They do this shrinking, right? So then, I don't know. I haven't read any. The longest report that mentioned partial remission was 5 years. I had one child in the case control, but this is the child who was diagnosed. She was 4. She was not on DKA at diagnosis, and that is an engineer. So he got a CGM the next day, and he placed her on a pump. I think like after 2 weeks. So then they had data daily. They were able to manage that, micromanage diabetes. That was not a situation of 99.8 other kids, right? I think there was also like one report of 8 years. So then that has been the longest that I have read about prenatal honeymoon phase. I think what we have learned is sooner is better because it's, like you have all this destruction, daily destruction, right? That's my point, when many clinicians were trained, when I was initially trained until I met Aaron Michaels, when he came to give me a talk. Aaron Michaels came when I was a fellow to give us a talk, and I was like, whoa. And he said, like, guys, this is an autoimmune condition. What happened with the autoimmune condition? There's a constant destruction. We're not really curing that disease with insulin. And I was like, so then why do I keep learning about insulin it is not curing the disease? So I envision type 1 diabetes care as switching from the 98% diagnosis at the stage 3 to ideally, 95% diagnosis at the stage 1 or stage 2. Finland, that has higher prevalence and incidence of type 1 diabetes, they do HLA genotyping as part of the neonatal screening. Like all of you guys, the ones who were born in the US, before you went home with mom, with your family, you receive a neonatal screening for many of the metabolic conditions that can definitely be detrimental to life. So that is what in Finland they get for HLA genotyping. So they can identify them early on, and those with higher risk can be monitored closely. So Breakthrough Type 1D is trying to move policy, engage with policymakers to do that. So then they know from day 3 of life if they have high risk HLA. Genetics only play 30% of the role in clinical development of type 1 diabetes. So that's why, my research is in the non-genetic etiologies, support for beta cell, but I'm an optimistic scientist. So I would say we may, maybe, I'm very enthusiastic about stem cells, learning how to behave as pancreas. I think there's a lot of promising on that. I just love the whole idea. But I think it's very different to living with type 1D for 20 years and which are your options. And I feel for your family member, I'm excited about the option of stem cells. I have talked with people who have been through those therapies, and by now it's only available trials for adults, not yet in children, because we need to prove that they are safe for children, because I need to receive also immunosuppressive agents, right? But early on, as soon as we can. That's why, number one, we need to spread the knowledge about if you have a child with diabetes, a family member with type 1 diabetes, and my message to the PCPs, and that's why I mentioned insulin is a growth factor, remember? So then we know, I know that children should gain 2 inches per year when they are not within puberty. So when a child comes to the PCP because of weight loss or not changing the size of their pants, the kid has been with the same size of shoes for the whole year, that is not normal. And when I talk with pediatricians, tell them, when a child is not growing, you must do a glucose check. Why? But why? Insulin is a growth factor. So then, and if we talk with families, and I have been talking with them since 2011, they mention, oh yeah, I noticed that he was not gaining weight despite of eating well. And that two options, if you as a child are eating as your usual and you're not growing, that two options, you have malabsorption or your hormones are not really matching your energy intake. And what is the main hormone in charge of that? Insulin. So I tell the PCPs, please don't look for the police. We need to look for failure to grow. Delayed linear growth is not really complicated. I think I think all the PCPs, all the pediatric practices, they must have a glucometer. You don't need to get an A1C machine. You need to get first urine dip and a POC. That's it. And when PCPs call me, because we are a referral center for Central Pennsylvania, so then I tell them, what is the sugar level? Oh, I haven't checked that. Okay, you get a BMP stat. And then I received a child with new diabetes diagnosis, but he was not on DKA. That means like we were able to save some beta cells, right? So then I think that translating the science to the clinical care of humans who are the ones having that disease.
Maybe we can conclude with one last question. So, I'm teaching a metabolic regulation course, and we talk about molecular mechanisms, but I always connect mechanisms to structural determinants of health. And I say, and we read that the zip code where you live in the US determines which diseases you will get. So between these remitter and non-remitter groups, although they were both relatively good in terms of
yes.
their control, was there a zip code difference that is potentially correlated with the income of the family?
We did COI. We did the Children Opportunity Index. We also measured social vulnerability index. There were no differences. So with the social vulnerability index that came from the CDC data during the pandemic, we believe that the main issue was that, for example, the same zip code, you have a lot of heterogeneity because depending on the neighborhood, they can be very close to each other. You can see a lot of differences. But then in the rural areas, so then they were not similar. So then when I talk with Joshua Joseph from Endo Society, so I'm like, maybe the SBI is not the best marker for your specific population, the geographic distribution of how they live. But we tried the Childhood Opportunity Index, and there was no statistical significant data. Again, this is not North Philly. In North Philly, I believe like maybe the COI would have been a better index. So what I did, because my initial Childhood Opportunity Index was, I used the ordinal scale, very low, low, moderate, and high. Now we are switching to the most recent COI that is a numeric scale. We hope to get results, maybe some association with the numeric score, of the COI. But Childhood Opportunity Index is basically how many opportunities you have to have better access to different things, education and foods and all of that. For this specific study, I did not screen for nutrition security and food insecurity, but for my clinical trial, the Nutri-Beta, I have screened them and I found some positive screening for nutrition and food insecurity. I don't know if maybe that was the reason that motivates them to get 12 weeks of healthy foods at no cost, maybe. But that was my piece of work, trying to give access. I think like everyone needs to have access to research, no matter where they live, no matter what is your background, because if you have the condition, you have the same right that other kids to get the help.
So lunch is being prepared. So then thanks to Dr. Huerta-Saenz for being here, for giving